immersive reality platform for surgical planning and resident training in low pelvic surgery. This project was a collaboration between the University of Illinois at Chicago and ImmersiveTouch. Models were constructed by ImmersiveTouch and viewed using their ImmersiveView software. The primary and senior authors have no financial stake in ImmersiveTouch. ImmersiveTouch did not provide any financial support towards this project. Low pelvic surgery involves challenging anatomy in a confined operative field. Virtual reality shows promise in surgical planning and operative rehearsal. Herein, we present a novel, immersive virtual reality model of the low pelvis. The user is placed in a virtual space and is able to manipulate their surroundings with handheld controllers. Although this is difficult to represent in 2 dimensions, the user will have the visual perception of being fully immersed in a 3-dimensional room. The model will appear in front of the user as a 3-dimensional object and can be moved and rotated in a fashion similar to how one would manipulate a real 3-dimensional object. The object can be enlarged and shrunken as the user sees fit. An array of useful manipulations and measurements of this model can be performed using a toolbar that can be easily summoned with a click of a finger. Each anatomical structure is coded as a separate mask, allowing each structure to be manipulated individually. For instance, the skin and musculature can be hidden to reveal the underlying anatomical structures. Alternatively, the opacity of the layers can be adjusted. Another feature of this model is the ability to create custom cross-sections. This allows for exploration of cross-sectional anatomy from any conceivable plane. The software also allows the user to overlay the patient's cross-sectional imaging onto the virtual model to correlate 2-dimensional imaging findings with 3-dimensional structures. The opacity of the scan can be adjusted as needed. The cross-section can then be moved to focus on the anatomical area of interest. Measurements of distance and angulation can easily be made using a 3-dimensional ruler. Multiple cross-sectional planes can be added to the model and oriented in the virtual 3-dimensional space as desired. The planes can be moved simultaneously and in all directions to allow for a 3-dimensional understanding of the cross-sectional imaging. The following 3D model was created from preoperative cross-sectional imaging obtained from a patient in our practice. The patient is a 70-year-old male with a history of Crohn's disease and recurrent anal fistula who was found to have an extramucosal anal canal adenocarcinoma thought to have arisen from his anal fistula. The lesion was clinical T3N1 at the time of discovery. Placing the patient in the supine position, we begin our exploration of the patient's internal anatomy. Here, we remove the visceral fat to optimize visualization of the pelvis. The user is able to navigate through the patient's body in 3 dimensions using intuitive hand gestures. The mass is seen shaded in green and centered within the posterior perianal region. Reorienting the model and approaching the lesion from the perineum, we can get a better understanding of how the lesion interacts with surrounding structures. The mass extends superiorly from the posterior perianal region behind the iliococcygeus muscles to the level of the low rectum, approximately 3.2 centimeters from the anal rectal angle. It extends to the anterior tip of the coccyx without abutting it. It is multilobulated and septated, measuring 4 by 4 by 8 centimeters. The complex three-dimensional geometry of the lesion is best understood when viewing it in 3 dimensions. We can layer cross-sectional imaging onto the three-dimensional model to enhance our understanding of the relationship between the lesion and the surrounding structures. The lesion can be seen exerting a mass effect on the mesorectal fat. The mass extends through the pubococcygeus muscle anteriorly, involving the posterior anal canal. The internal and external sphincters are disrupted posteriorly. By combining cross-sectional imaging with a three-dimensional model, a more complete understanding of structural relationships is obtained. The patient subsequently underwent neoadjuvant chemoradiation therapy followed by abdominal perineal resection and adjuvant chemotherapy. On pathological examination, the lesion was classified as post-treatment T3N0, and the surgical margins were free of tumor. The tumor invaded into the muscular apropria of the rectum. It measured 5.7 centimeters in greatest diameter. No lymphovascular invasion was identified. This technology provides the clinician with a three-dimensional interactive model generated from preoperative imaging and can be constructed with a turnaround time of less than 1 day. It has potential applications in the area of surgical planning, surgical education, and surgical simulation.